Hello and welcome back. This is the Colorado Dental Assisting Schools Week 3 and 4 lecture, and this one we are going to talk about radiology theory and practice. Let's get started. Today, radiology has advanced in many ways, making it much safer to practice. I know a lot of you might be a little freaked out about the radiation that is involved in taking x-rays, but today we are going to learn about safety, how to keep yourself safe as dental assistants, and also how to keep your patients safe. So a couple of years ago in dentistry, we used to use film, and there are still some offices out there that utilize film. There's nothing wrong with that. It still takes a great x-ray. Some of the disadvantages of film, though, is that you have to have a processor, which includes the developer and the fixer, which are two different chemicals that we use to develop the film, as well as it takes a lot more time to, take the film and develop it. And then by the time we're done with it drying and getting back to the patient once we've examined it, we might need to retake that film, but we don't know until it's completely processed. Where nowadays we are using digital x-rays. So what that means is we use a digital sensor that plugs into the thumb drive of the computer. And it's pretty amazing. These images come up instantly. You can make changes to them. Some of the office software will also show the doctor's caries on the film, or if there's a crack in the tooth. It allows us to measure from the root of the tooth to the apex, which is pretty amazing when we're looking at root canals. It's easy for us to send a referral transfer and send all of their information to that office, as opposed to previously we had film. The film stays at the office because the doctor owns that film. So they used to take a copy of it and then print it out and send it, which we all know sometimes printers do crazy things and it never really quite comes out the way you want it to. That made it really hard to do a referral, and a lot of times we would have to retake x-rays. But now with digital, it's instant. We can email it to someone safely in a locked email that's password protected, or, we can see it immediately on the screen as we take x-rays. So it has a lot less radiation that's involved because it doesn't need to be exposed as long as the film did under radiation to capture that image. So it's pretty amazing. There are no limits that are set for any diagnostic exposure from the American Dental Association. So we as dental professionals have to practice what OSHA calls ALARA. And ALARA means as low as reasonably achievable. So that means we're going to take every reasonable measure to ensure that the occupationally and non-occupationally exposed persons will receive the smallest amount of radiation possible. So what does that mean for you as a dental assistant? That means you cannot be in the room when these films are being exposed. You cannot hold the RIN or the x-ray sensor in the mouth of the patient, because then you're exposing not only your fingers, but your hand and wrist possibly. Yes, we do use cone beam imaging. So you don't want to be on the other side of the cone beam holding it, but you also don't want your hand to be exposed either. So to stay safe, we leave the room and push the button. Please don't get into any bad habits. You will see people do things out there that, we don't suggest doing. And it's unfortunate, but, people kind of get comfortable and think, oh, well, nothing has happened to me yet, so I'm going to keep doing this. You need to stay safe and practice safety every day. No matter what, no matter how long you've been doing this, you need to practice ALARA. The other bullet point you see there on the bottom of this slide, it tells you that we need a lead vest. The lead vest should have a thyroid collar attached to it. If not, they do come unattached and you can put it on separate. It is really important that we protect the rest of their organs with the lead vest. If for some reason it had a malfunction and the cone beam, the radiation didn't just stay in that area, we want to be able to protect all of their vital organs from being exposed to any unnecessary radiation. Why do we take radiographs, right? Why are we taking x-rays in dentistry? Well, we would consider this a standard of care. Without it, we can't see past the gingiva into the bone. We can't see if there's an infection going on in there. There are some symptoms that could lead us down that road, but we really want to make sure that we are giving the best possible care that we can provide. So we cannot make a proper diagnosis without x-rays, and basically we can't practice dentistry without x-rays. This is considered legal documentation. They must be labeled with the patient's name, the date, and the patient's date of birth. All of that will be in our chart, so we don't really have to worry about it whenever we're doing digital films. If it was going to be a set of films that you were processing, then on the FMX chart that you mount all of your films on, you would need to write in there the patient's name, the date they were taken, and of course that patient's date of birth. Radiation misunderstanding. This is pretty common. We have patients come in and tell us wild things that they saw on TV or something that they read on Facebook or the internet or Google. So this one is just saying the patient states, I don't want x-rays because I saw on a TV show I'll get brain cancer. So we want to ask you, how are you going to, one, calm this patient down, and two, give them an explanation that not only will educate your patient, but make them feel comfortable while they're in the chair with you. So your explanation is hopefully something along the lines of, today's radiation exposure from digital x-rays are safer and less harmful than in the past. One really great fact in Colorado is that we do get more exposure from the sun in 20-minute period than we do from 18 films. 18 films is considered a full mouth series of x-rays, and that's what we'll be practicing today. We call them an FMX for short. Do explain to your patient that they will be given a lead vest and that the radiation is a cone beam image. So that means it will stay within that area. It's not going to bounce around the room. It's not going to move around the body. It is going to strictly stay in that area. Also, within our sensor, there is a lead piece in there that stops the radiation from passing through the sensor and going through the rest of the body. And it stops it right there, just like the lead vest does. The films also have a lead piece in them as well. The other reason for that is so we can capture that image on that side of the film. We don't want to overlap teeth on both sides of the mouth in the image. So there's a piece of lead inside of the sensor that will stop that from happening. You can talk to them about background radiation, radiation in food, water, man-made radiation, that's, your cell phones, your microwaves, your smoke detectors, anything like that. There is an example of the electromagnetic spectrum here for you, so it kind of shows them where they're at when they're taking any medical or dental x-rays. Ionization. Although x-rays are safer nowadays, it is important to know they can cause cell damage if exposure is amplified. So ionization is the harmful effects of x-rays in humans. You did read about this in your chapters in your textbook. So please, if you have any questions, let us know. We are happy to answer any questions you might have from the homework reading. The cause is a disruption of cellular metabolism and permanent damage to the living cells and tissues. What do we know happens whenever we have any disruption to cellular metabolism? It could cause cancer, right? That's why we follow the ALARA concept. So as low as reasonably achievable means that for every single patient, we will have an individual treatment plan, and the doctor will decide whether or not they need x-rays. We aren't going to say, well, every year we have to take your bite wings because the American Dental Association says we have to, so we're going to do it anyways. If the doctor knows they just had x-rays previously, or let's say they don't have anything going on in their mouth, they don't have any existing restorations, they don't have any caries that we're worried about, we might wait 18 months instead of doing it every 12-month period and wait another couple of months before taking that full mouth series of x-rays or possibly just those 4 bite wings. So every single patient will have an individual treatment plan, which is going to give us that advantage of making sure that we're safe and also that we're providing them the best dental care that we possibly can. Requested x-rays. This is what you're going to see in the dental field. All of these different variations we are going to talk about and practice. So FMX is your full mouth series of x-rays. That is a full 18 films, and it covers the entire mouth. The BWX is short for bite wing x-ray. On children, for bite wings, we do one on each side. For adults, we will take 4 bite wings. So we will take 2 of the molars and 2 of the premolars. For a PAX, that stands for periapical. You will hear that referred to as a PA. The doctor might ask, hey, can you go get a PA on number 6? You know, I really can't see it. Maybe it cut off the apex in the first one we did, or maybe that's what they're coming in for a limited exam that day. It just depends. The periapical basically shows us the entire anatomical tooth. So it will show us from the crown of the tooth all the way past the apex. We want to get anywhere from 2 to 3 millimeters past the apex on the x-ray, because if there is some sort of infection or some sort of inflammation around the periodontal ligament, we want to be able to see that past the apex. The panoramic x-ray is referred to as a pano. That one will move all the way around the head, and it will show your TMJ, your upper and lower jaws, and part of the sinus. That one is usually one we use for oral surgery, orthodontics, and any trauma that might have happened. We can usually get a pano and see what's going on. A cephalometric x-ray is commonly used in oral surgery and orthodontics as well. The cephalometric is going to show a profile picture of the skull, the entire skull. So we will either see the right or the left side of the patient, and it'll give us a good idea of their bite and what kind of treatment they could possibly need. Most common standard films. So this again is just going over each different film. It talks about bite wings. So the reason that we take bite wings is so we can see interproximal space. We want to be able to see in between the teeth if there's any caries hiding in there. That is how the doctor will be able to diagnose if they need a filling. If there's any restoration to overhang and we have a food trap that's possibly causing that restoration to fail, we will be able to see it in a bite wing. Any recurrent caries or recurrent decay. The periodontal conditions, will be we'll be able to see in this film as well, because it will show us the bone level. So if they are starting to have bone loss, it will show on the bite wing film. Also, their calculus deposits. So if they're going in to have a cleaning that day and a prophy, it will tell us what type of cleaning they need. Will they just need, you know, a regular prophy? Is this a standard 6-month recare? Or do they have more calculus deposit and possibly need full mouth debridement, maybe a deep cleaning like an SRP? Oral surgery will also need bite wings. A lot of times oral surgery is going to need a full mouth series of x-rays, and bite wings are part of that. Your periapical radiographs, this is where we can see the apex as well as the root. So it will show normal morphology, any periodontal status, like I was telling you, if there's any sort of swelling in the periodontal ligament or if there's an abscess at the apex of the tooth, we'll be able to see that as well. This is a picture of an occlusal radiograph. This is most common in your pediatric office. The reason that we like to take these is we can see if there's any development going on or possibly any trauma that might have happened. Any unerupted teeth would be the development that's coming through. With kids, you basically put the little sensor in their mouth, and I like to tell them to bite down on it like a cookie. And then you can either take a maxillary or a mandibular occlusal radiograph, and it will show all of the anterior teeth. This is an example of a panoramic radiograph. It is cut a little short on this film, I apologize. It should show all the way to the TMJ, which is your temporal mandibular joint. This is an example of the cephalometric x-ray. So you can see it's just either the right or the left side that we've taken, and it's going to be that profile of the patient. These are other types of x-rays that are taken in a dental office, depending on where you work. You could take a CT, an MRI, a 3D cone beam image, the PA skull view, or the plain film tomography. It really depends on which office you work in. If you work in a hospital, you might see some of these. A lot of them will be more in a hospital setting. But in some of our endodontic and oral surgery offices, they do have 3D cone beam imaging. This is a picture of an X-ray machine. You can see the tube head, the position indicating device, and also the extension arm. The control panel will either be on the inside with the machine or the outside of the room. You don't have to worry about adjusting the control panel because we actually pay a company to come in and make sure the MA and KVP exposure buttons are correct and that we aren't exposing our patients to too much radiation. The only time we really change it is for a child. However, what I've noticed is when we plug in the size 1 sensor to take an X-ray on a child, it will automatically sense that and change the KVP for us. If your X-ray machine doesn't, when you get training in that office, they will let you know exactly how to change it when you're taking an X-ray for a pedo patient. You want to remember to hold down the button all the way until it's done beeping. Please don't push it really quickly and walk away. It will send an error code and then we have to start over. So just remember that button will require that you hold it down all the way and wait. It will continue to beep. Once it's done beeping, you can let go and go reposition the sensor in the patient's mouth. This talks a little bit more about X-ray production and what needs to happen. This is telling you X-rays are produced whenever high-speed electrons are suddenly decelerated or brought to a stop, and some of their kinetic energy is converted into electromagnetic radiation. Here's a picture of our sensor if you were to open it up and look inside. So it has your filament in there, which is the part that usually breaks if we drop it. So you want to be careful. It's kind of like a little light bulb. Everything is attached in there, including the little cord that's going in there, which is giving it power, right? We want the cathode and anode to be able to receive that spark of electrodes. This is a picture of how X-rays are produced. This is showing us exactly what it looks like if we were to open up the sensor inside. So you can see the little heated filament in there. It looks like a little light bulb. We need to be very careful because if you drop the sensor and it breaks, we will not be able to take any more X-rays. And these are not cheap. So please keep in mind to take care of it. You don't ever want to pull on the cord where it's attached to the sensor because if this gets pulled and it detaches, again, it will not be able to take X-rays, and that makes your day really hard. You know, we really can't do dentistry without X-rays. So please take good care of these. Please do not drop them. You never want to step over the cord when you're leaving the room. Please go out of the side that you've entered and do not cross over the cord. If we see you crossing over the cord and you trip on it and break the sensor, you will be disqualified from the radiology exam, and there will be a fee for breaking it. Conditions necessary for an X-ray. So we did talk a little bit about this, the sudden stoppage and all that. This is all happening when you push the button. So you pushing the button and walking away really quick and it sends an error means that the production of high-speed electrons and it being able to stop and capture that image didn't complete. So just, again, make sure you hold down that button the entire time until it's done beeping. That way we can capture the image and our patient doesn't have to wait for us to do it again. Light versus dark. So anytime you see density, that is going to be a difference in black and white. So anything that'll be a little denser will be your caries, the space and air between the teeth. The gingiva will be a little darker. The light, denser areas are going to be radio opaque. That is going to show any sort of bone, enamel. It will show any sort of restorations in the teeth. So fillings, crowns, bridges, any posts, anything like that are going to show up radio opaque. What we would consider the black areas we call radiolucent. Again, that's going to be the pathology in the mouth. So if there is any sort of infection, it will show up as a darker area and it will be what we call radiolucent. You do need to know the difference between density and contrast, which are going to be the shades of gray in there. A lot of these systems will work a little differently on each computer. So it really depends on where you work and what system they have, but they will train you and show you exactly how to use it. This is showing you an example of a full mouth series of x-rays. So you can see all 18 films here. What I want you to take away from this slide is that you do not, under any circumstances, start doing retakes immediately. And a retake means, okay, I cut off the apex, I can only see half the tooth, I'm just going to retake it really quick. You don't want to do that. That is overexposing your patient to too much radiation. So what the pink and yellow is showing you here is that these will overlap. So even though you might not have gotten, let's say, number 2 or the distal of 3 in your first posterior PA, you will more than likely get it in the second PA. So my suggestion to you, and what I really want you to do, is complete your FMX and then go back and do retakes. That way you can look at all of your films and make sure you weren't spending 5 to 10 more minutes trying to capture this one tooth when all you had to do was move forward to the next x-ray, and what do you know, you captured it in that one. Because if you take a good look, you can capture anywhere from 3 to 4 teeth in an x-ray at a time. So please don't waste time on retakes, and remember that a lot of these will overlap, and that's good. We want that to happen because we can see different angles in our proximal space and also the periapicals at a different angle in each film. This is showing you how to take the FMX if you were to write it out. This is more of a study guide. It's kind of hard to understand right now until you physically do this lab. So it's telling you where to start in the mouth. This might be something that you want to take a look at and kind of write notes on while you're watching either the video on our student portal or while you're in class doing it. But this is just reminding you where you're going to start. I know your book reviews, if you have a patient that has a really high gag reflex, you want to start on the premolars and then move posterior. That is a great suggestion. However, for this FMX, we do want you guys to do it traditionally. You can do it any way you want after that, but this is the fastest way and the best way to get it done because you don't have to go back and forth and it's easier to switch your RIN. So the next couple of slides are just telling you exactly how to take your FMX as far as putting the RIN together and placing it in the mouth. Let's talk about techniques. We have 2 techniques to talk about. One is the paralleling technique, and bisecting angle technique is number 2. So when you're doing a paralleling technique, you want to keep the film and the tooth parallel to each other. So what you see here is this is as if we put the film in the mouth and the patient would bite down, the bite stick would be down here. The film needs to go pretty deep into the mouth to be parallel with the tooth. A lot of times we'll have a patient with a lot smaller and shorter palate, so we can't get the x-ray sensor all the way in for it to be parallel, and we have no choice but to do a bisecting angle technique. That is okay. The reason we have these 2 different techniques is so we can open what's called in between the furcations, which is in between these root surfaces. So this maxillary molar has 3 roots, but it's sometimes hard to see if they overlap when we're taking a paralleling technique x-ray. We want to be able to see all 3 of them separate and not let them overlap. By bisecting, that opens it up and we can see them individually. This is most common used in endodontics when we're doing any sort of root canal treatment. You want to remember to always do a final check on your RIN before you place it in the patient's mouth. Again, this will help you cut down on any unnecessary radiation because you don't want to miss the film and realize you set up your RIN incorrectly, or your position indicating device, however you want to call it. What you're seeing here is a bullseye. This needs to be dead center whether you're taking a anterior or posterior PA. This film or the sensor needs to be right in the middle, and you need to have a bullseye every time you check it. If it's off to the center over here, then you know you need to recenter your ring. This is showing you what it looks like in the patient's mouth when we are taking anterior maxillary PAs. So it's showing you exactly what it should look like when we're setting up the cone of the x-ray. It should be following the bar here, and as as centered as you can get it in the ring. I don't want you to get too attached to the ring. If someone has really long roots, you can come above that ring. You want to be careful though with your angle, because if you go too far up, you could foreshorten it. And the way I want you to remember that is, if the x-ray head is too far up and it's pointing down at the patient, it's almost as if you're tall, and when you look down on someone, they look shorter than you. That could cause your x-ray to be foreshortened, which is what looks like happened here, because these roots look really short, and they're probably not that short. In reality, it should be dead on like this, where we're looking straight onto the tooth and the roots don't look short to us. If you're too far below the root and you're pointing up, it could elongate it and kind of stretch it out and make it look funny. So you want to be careful with the angle. Try to keep that bar as straight as can be with the x-ray head, and you're in good hands. Remember, when we're taking PAs, we want to be able to see the apex and a little bit past the apex. So we want anywhere from 2 to 3 millimeters past the apex. This is a great shot because not only can we see anterior, but we can see past the apex of the tooth, all of this healthy bone down here. We want to make sure nothing is going on down there. The doctor wants a good look at it. This is showing you a posterior PA on the mandible. This is the lower left side. This is showing you a PA on the lower left as well, but their angle was off. So if our angle isn't straight with the rin, then we could possibly have some overlapping, and it's really hard to see in our proximal space. This is an example of bite wings. So for an adult, we need to be able to see the distal of the furthest tooth. If they have their wisdom teeth, please don't try to choke the patient out trying to get the wisdom tooth in this film. If they have wisdom teeth and you can't get it in the bite wing or the PA, that's okay. We will just go ahead and ask the doctor, hey, you know, they have some wisdom teeth in there and they're hard to get to. Do you want a PA? Or I'm sorry, do you want a pano? And the doctor will let you know if it's okay to take a panorama. You don't want to stop taking your FMX. Please go ahead and finish the FMX, because in the panoramic x-ray, it's really hard to see up close to the films that we get from the FMX. So you don't want to trade one for the other necessarily, but you might need that film extra. This is giving you an example of the foreshortening and elongation that I was telling you about. So you don't want to elongate it where it's stretched out or foreshorten it where they look really short. So this is the same patient, and they've taken the x-ray 3 different ways as far as their angle goes. So what it's showing you is exactly where the x-ray head should be pointing. And when they bite down on the rin, the bar will point the exact same angle. So you want to pay attention to that bar. This is giving you an example of what a panoramic x-ray looks like. So the patient will usually have somewhere to hold on to hold their body still. You'll line it up, and you usually will walk around the corner, and that cord will stretch out with the button. You'll hold the button down until it's completely done, and then you can go retrieve your patient. Here's an example of an adult dentition in a panoramic x-ray, and also a mixed dentition. So what you see here are primary and permanent teeth. Couple more examples for you. This is showing you an example if we accidentally left the patient's jewelry on. The same thing would happen with their eyeglasses. So don't let them continue to wear their safety glasses, their eyeglasses, or sunglasses at all. Jewelry needs to be taken out, whether it's earrings, a lip ring, tongue ring, nose ring, anything that's going to get in the way and interfere with the x-ray. If that happens and it ricochets and now you can see it in here and it's hard to see these teeth because of it, we will have to retake it. And again, that will be unnecessary radiation. So let's make sure and think ahead and keep our patients safe. This is showing you the angles. So correct, incorrect, and then too flat, incorrect. So we definitely want to pay attention to the angulation. You can see here on these x-rays when they develop how they look pretty funky after they're taken incorrectly. Last thing we have for you are some tips in safety. So take a good x-ray the first time. Obviously, all of us want to take a good x-ray the first time. But what I want you to take away from that is, keep in mind that we need to remove earrings for panoramic x-rays, not for all x-rays, just for panos. Keep in mind that you're using the RIN, you have a bullseye, your sensor is on correctly. Don't hold the sensor for the patient. You always use a lead apron. Even if someone says, oh, you know what, we have this new system and you don't need it anymore, a lot of times patients are going to ask for it because we've been using it for so long. Remove jewelry and eyeglasses. Do not pick up dropped films unless finished with all exposures. If you're using film, an old film system, and you drop one, please don't pick it up with your glove and put it on the clean working space. Just leave it on the floor, and when you're done, you can pick it up and complete your films. If you have a sensor, under no circumstances is it okay to drop the sensor. And if you're wondering, well, what if I do? What if I make a mistake and I drop it? People make mistakes. We understand. We have a video on our student portal that gives tips and tricks on how to hold on to that sensor. So that way, even if it falls off of the RIN, or for some reason it just slides out of your hand because your fingers are slippery from saliva, you'll still have the cord in your hand, so you won't drop it. So please, once you're done here, go back and watch that lab video on how to make sure that you don't end up dropping the sensor. Stand at least 8 feet away from the x-ray head or behind a protective barrier. Keep exposed x-rays separate from unexposed film so they don't become mixed up. We don't use film in our office. You don't have to worry about that because the x-ray sensor will continue to take new x-rays. However, if you are using film, you don't want to mix them up because if you retake it on one that's already been exposed, it will erase the previous one and give you a new one. So you don't want to do that. Be as gentle as possible, but realize some x-rays are uncomfortable. You want to go as quick as you can. If you have a patient that gags easily, we can sometimes numb the back of their throat. To be honest with you, it's not always that fun to use that anesthetic spray. So if anything, if they're more comfortable and they want to hold on to it, that's okay. But sometimes you have to place it in there and talk them through it. It's all about you making the atmosphere something that they enjoy and they feel comfortable in. So talk to them and let them know, okay, I'm going to put this in there real quick. I know you're in pain today, but we need to get an x-ray of this tooth. I'm going to run out there, push the button, and as soon as it's done beeping, you can take it out of your mouth. You don't have to wait for me to come back in the room. Whatever you need to tell them to make them more comfortable, please be sympathetic with your patients because x-rays aren't very much fun. And just let them know, we will be done really soon. It won't take that long. I just need you to cooperate with me. Wearing a film badge is important, but it is not always required by all offices. The office you work for will explain to you whether or not you need a dosimetry badge. It will have your name on it. And what that does is it tells us whether or not you're being safe as an employee. So you don't ever want to take it outside because it will be exposed to the sun and the sun will give false readings of radiation. So keep it in the office. Don't take it home. Do not leave it in the room, though. If you go, let's say you have Mondays off or Tuesdays off and the other team is working, they're taking x-rays all day and your dosimetry badge is in the drawer getting exposed. So make sure you have a safe place to put it in and make sure that you guys are practicing safety. If you have any questions, you know how to get a hold of us either through email or give us a call.